Sir, would you please step here into the witness box and raise your right hand so that you can be sworn?
Yes, I do. Okay. My name's Troy Holdeman, Troyholdeman.
Good morning, ladies and gentlemen of the jury. Dr. Holdeman, good morning.
Morning.
How are you today?
I'm okay.
Good. The jury's heard your name. Would you tell these ladies and gentlemen your profession, sir?
Sure, I'm a family medicine doctor.
All right. And you were one of the treating doctors that saw Terry Bruner at Via Christi beginning on the 10th?
Yes, sir.
Okay. And you understand, I'm going to ask you some questions about what you recall about Mr. Bruner and what's in the records.
Yes, sir.
All right. And before we do that, I think the jury probably would like to know a little bit about yourself,
Great.
just so, I mean, they have to do a number of things, including decide how much weight to place on someone's testimony. Could you tell them where you were born and raised?
Sure. Newton, Kansas, just up the road. Sorry. Newton, Kansas, just a small town just north of here.
All right. And could you tell them where you went to college?
Kansas State University.
All right. And then medical school?
KU, Kansas University.
All right. And when did you graduate?
Medical school in 06 and residency in 09.
All right. And would you explain to the jury what a residency is, what you did for 3 years after you graduated from medical school?
Sure. It's on-the-job training. You're a doctor when you graduate from medical school, but without a lot of experience, they don't just turn you loose. So you spend 3 years under other physicians, just kind of with on-the-job training.
Is that why you put that in quotes, because you are a doctor, but they don't treat you like a doctor yet?
You're a doctor by title, but your confidence isn't there, and you still need supervision.
All right.
So,
and where did you do those 3 years of residency training?
through Via Christi here in Wichita.
All right. And then when you're done with that, what does a doctor do to become established and start to practice?
First, most physicians become board certified, so take a test in their particular field, just for credentialing purposes, and then decide where you want to practice and either hang a shingle, go on your own, or join a group.
All right. And did you become board certified?
Yes, sir.
All right. In what area?
Family medicine.
Okay. And could you tell the ladies and gentlemen of the jury what family medicine is? I mean, what types of things do you treat and see?
In the world of medicine, family medicine is probably the most broad spectrum of care. You're trained to see children, adults, inpatient, outpatient, so in other words, hospital or office setting. Some family medicine doctors even deliver babies. At Via Christi, we do a lot of focus on inpatient and office setting, so clinical medicine.
All right. And do you have both an office-based practice and a hospital-based practice?
Yes.
Okay. Would you tell us a little bit about that? What percentage and what do you do at those two places?
Me personally, in my group, we have our own group of patients that we're their primary provider, and I spend probably 80% of my time in the office, typical office visits, routine care, but then I also, if one of my patients gets sick and goes to the hospital, I follow them there too. So I probably spend 20% of my time at the hospital, 80% in the office.
All right. And to take it a little bit closer home to this case, do you treat patients who have pneumonia?
Sure.
Is that something that's common? Is that something that you...
Relatively common, yes.
All right. And you know about the disease process and about the treatments for it?
Very well.
What is the treatment for pneumonia?
Simply put, antibiotics.
Okay. Are you also well-versed and trained and experienced in sepsis?
Less so, but yes.
Okay. And lastly, meningitis?
Yes.
All right. And is it your job to see people and to listen to a history and find out how they've been feeling for a number of days and then try to issue spot and say, okay, we've got a problem here, or we've got a problem there, I'm going to look in this direction?
Yes.
All right. In addition to the work that you've described for the jury, do you also work in emergency rooms from time to time?
I have in the past. Currently I don't, but I have in the past.
All right. And also, have you engaged in a number of research projects?
Yes, sir.
Okay. Have we covered your background and training pretty sufficiently, do you feel, or is there something else we should talk about?
I think for the most part, that's...
Okay. Where were you working on March 10th when Mr. Bruner was brought to Via Christi?
I would have been on the medicine team, so we take unassigned patients, in other words, patients without a local physician who would assume their care. So I would have been on the medicine team once they get admitted to the hospital. So,
all right. So when the jury looks at the records and they see attending and they see Dr. Natvig and then they see your name, what does that mean to them? What should it mean to them?
Like I mentioned earlier, I was a resident at that point. I was about halfway through my residency, so I was the resident on call for unassigned, so I would have been the first to see Mr. Bruner when he hit the ICU, and then Dr. Natvig would have been updated or kind of informed by me, and then we, together, would help care for Dr. Bruner, or
okay.
Mr. Bruner.
And you mentioned that you were the resident, but when I first talked to you on the phone and you said, why are you calling me? And I said, well, it's my experience that the resident does most of the work and then he or she is supervised by the doctors. Is that true?
Yeah, that's true.
I mean, you did a lot of work on this case with Mr. Bruner, didn't you?
Yes.
Examinations, taking a history from whoever you could get it from, talking with the consultants. Is that correct?
Yep, that's true.
Do you remember Mr. Bruner? Can you tell the ladies and gentlemen of the jury whether you remember him actually, other than just the medical records?
Yeah, I actually do remember Terry Bruner. He was, at the time of presentation when he came to me, he was one of the sicker patients I'd had at that point. So he did kind of stick out to me. As a resident, we talked about earlier, I'm still kind of learning and training, so you can be uncomfortable with situations, and I just know that he was a sick guy, and there was a lot of consultants needed to be contacted, a lot of things needed to be done, so I remember him.
Okay, so that was a busy patient for you in terms of consultations and meeting with people. Mm-hmm. Do you still recall to this day meeting with Dr. Rivero and Saloom and the others that were involved?
Yeah, not specific details, but yes, I remember talking with him.
Okay. And you said he was a pretty sick guy, and I want the jury to understand what you mean. So are you saying that when you say he's pretty sick, I mean, this doesn't mean like he's, sick in bed. I mean, what do you mean by that? By he was as sick as anybody you've seen?
Essentially, and I think it'd be hard to find somebody to disagree with this, but by the time we got to him in the ICU, Mr. Bruner was on the verge of death.
And so when you say he's one of the sickest patients I've ever seen, that's what you mean. He's just past the point where you think you can save the man.
Yeah, I mean, we always try. We always want to stay optimistic, but I think everybody knew that it wasn't going to go well.
Okay. Could you tell us a little bit about your exam as to why, you knew it wasn't going to go well, why this patient stood out and still stands out, after all this time in your mind today?
I'd say one of the biggest things was his neurological exam. Without him being able to talk and respond and answer questions, it's just based on what we can physically see and do with the patient. And, he didn't have any of the normal...
You can hang on a second.
Okay.
All right.
Is there security out there?
Yes, ma'am. They just escorted her to the elevator.
Okay.
Sorry about that, Doctor.
Those are great.
I think everybody was distracted a little bit, and I
Sure.
didn't.
I was just saying that neurologically, if I was going to do an exam on somebody that's awake that could respond, movements, move your eyes, do this, do that. He was unresponsive, not just verbal stimuli, but we assess for response to pain. So we'll either squeeze a fingernail really hard at the base, or we'll do a sternal rub where we push on their sternum and rub back and forth. And there was nothing that we could do to get a response, a meaningful response from Mr. Bruner. His pupils were fixed and dilated, so when I shined a light in his eyes, the pupils didn't react. Those are just some reflexes that kind of show brain function and kind of let you know.
Do you recall anything else about that physical exam that stood out in your mind or that's in your records that you think is significant for the jury to understand how really sick and past sick he was when you saw him?
The big things would be the neuro exam, but I do remember, I put in my record that he had bounding pulses, and just once the inflammation gets bad enough, it causes your blood vessels to dilate. So instead of trying to have to kind of feel for a pulse, it's just you can almost see it, just because his blood vessels were so dilated.
And what's going on with a person physically when that's going on, when their heart's just pounding like that and the blood's rushing through? What does that mean that's going on with the body?
It just goes along with everything else. Just this is no longer a focal isolated insult. This is whole body inflammation and a whole body process.
All right. And did you and the team at Via Christa that you were working with?
Let's hold up a minute. All right, let's try again.
Doctor, on your report, just so the jury's aware, when they get the Via Christi records, there will be a couple of reports written by you and a couple of handwritten notes written by you. Is that correct?
Yes.
And on the first page of this typed report, this is where you're talking about, you're telling the jury now what's in your report under physical examination. Is that right?
Yes, sir.
All right. And so you talked about the patient was already ventilated by the time that you saw him and examined him.
Yes.
Okay. And also, I think it says down here, the patient appeared in respiratory distress. Or that was the presentation. Would you tell the jury what that means when a patient presents in respiratory distress?
Respiratory distress and respiratory failure are kind of a continuum, just where breathing becomes more labored, more difficult, and then finally you're not able to breathe on your own anymore. But respiratory distress is breathing fast, struggling to breathe, difficult exchanging oxygen.
So when they read that terminology in the medical records, they can then understand that that's what someone assessed and that's why he was ventilated?
Yeah.
And then it says under head, ears, eyes, nose, and throat, you talked about the fixed and dilated pupils and then measuring those. What did you find under the lung portion of the examination?
In the record it says bilateral rhonchi, decreased air movement, mechanically ventilated. Sorry. Oh, slower. Yes. Bilateral rhonchi, decreased air movement, and mechanically ventilated.
The first term, what does that mean, doctor?
Rhonchi is just, there's basically 3 breath sounds that we listen for that are abnormal. Rhonchi is one of the 3. It's kind of, it's more coarse and, well, if I could explain the other 2 quickly, it'd kind of help. Crackles or rows are more almost like Velcro pulling apart, and it typically means fluid in the lungs and the air sacs kind of popping open. Wheezes are, we've all heard kids with asthma wheezing. Wheezing is more of kind of a difficult getting air in and out. And rhonchi is more of a coarse sound, and it usually means phlegm or debris in the larger airways.
All right, doctor. And continuing with your examination, you mentioned under the cardiovascular tachycardia or tachycardic. Would you explain what that means?
Just rapid heart rate.
All right. And under the extremities, is that where you mentioned the bounding pulses that you were telling the jury about?
Yeah, it looks like it.
All right. And the skin was warm, which goes along with the temperature. Is that correct?
Yeah, the temperature and the vasodilation, just those dilated blood vessels will make you feel warm.
Okay. What can you tell us under laboratory data and radiology that was done for the patient and helped you get to the point where you and the team of doctors are coming to an assessment or diagnosis for the patient?
Sure. The laboratory, I mean, the very first one there, white blood cell count 38,000. That's dramatically elevated. It's just a marker of infection or inflammation. Platelets 95, that can go along with sepsis. Once they get below 100, that goes along with overwhelming infection. Down to radiology, CT, effacement of the sulci. That just basically means, hopefully everyone's seen like a picture of a brain where there's...
Unfortunately, they have.
In layman's terms, there's lumps and bumps, and it basically where on CT, sometimes increased pressure can make everything start to flatten out. So you can imagine if you pumped the skull full of enough pressure, the nice valleys and peaks would start to become flattened a little bit.
Okay, and is that what is being interpreted here by you and the rest of the team based upon that scan?
Yes.
All right. And then the chest x-ray?
Bilateral pneumonia, so both sides.
All right, and then the jury will obviously have this to see and can go over it, so I don't want to belabor all of this too much, but let's talk a little bit about what was going on here. Was, in your understanding, in your opinion, in your diagnosis, and I'm just talking about the facts of Via Christi, was this a person who at some point had pneumonia?
Yes.
Okay. And would you tell the jury, even though I have a lay understanding, I presume all of them have a lay understanding, but what is pneumonia, medically speaking?
Pneumonia is basically, in layman's term, it's an infection within the little air sacs of the lung, the alveoli. It's a lung infection.
All right. And like any infection, if it's left untreated and the body doesn't fight it off, what happens to it?
Untreated pneumonia?
Yes, sir.
Progresses, worsens, can lead to sepsis.
Now, how does it lead to sepsis?
Sepsis is basically overwhelming inflammation within the body. And by definition, it's caused by an infection. So basically, the body gets to the point where it can't handle the inflammation anymore, and it just leads to cell breakdown, increased vascular permeability. In other words, the vessels become leaky. But basically, it's that there's an amount of inflammation, or in the case of sepsis, infection in the body, that it just overwhelms the system.
Okay. And so a person with pneumonia has this infection, and I assume it starts out small and can grow if left untreated.
Yes.
And what is the body doing to try to combat that while it's growing?
Making antibody. The immune system's fairly complicated, and even by the time the pneumonia started, some of the most basic functions of the body's defense have already been overcome just by the fact that the infection's in the lungs. So by the time you've got the pneumonia, you're really talking about, developing antibodies, and part of the immune system is sending those inflammatory markers to the infection to try to break down the bacteria and kill the bacteria and clear the bacteria. So, in some ways, by fighting it, it's also part of the problem.
Does it take its toll on the body?
Absolutely.
Can you look at a person whose body is fighting infection and tell they're sick, there's something going on with them?
Your Honor, the question's too vague, I think, to require a response. In this case, I think we're trying to sort out what someone would have known when, and I object to the form of the questions.
I'll make clear, Your Honor, I'm not talking about anything other than generally with this particular fact witness, because he's not going to be offering opinions about the days before, because that's not his purview in this case. I'm just talking about the entity that is pneumonia and then sepsis, and then I'll get to meningitis.
If there's ever any questions that you don't understand, make sure that you get a clarification.
Okay.
But if you understood that question, you can go ahead and answer it.
Okay. Would you just repeat it for me?
Sure. The question before, I think, was we talked about a body fighting off pneumonia, and it takes a toll on a person because they're going through something. There's this fight going on inside their body. You remember that? Mm-hmm. And so my follow-up question was, can you look at someone who's fighting through a pneumonia and tell that they're ill or they're sick because of the way that they look?
Again, I think the question is vague as to time. I don't know if he's talking about whether you can look at him when he saw him in that fashion, or whether you can look at him and project back as to what the symptoms would have been hours before or days before, Your Honor. I think that's really important in these cases.
Well, I think the question is pretty clear, and if you want to cover that on cross-examination, that would be appropriate. You can answer.
Okay.
Do people with pneumonia look sick?
Yes, typically.
Okay. And as that pneumonia continues, I just want you to assume hypothetically that it's left untreated, and it continues for a period of 2 or 3 days. Does a person look sicker and sicker as on the inside they're getting sicker and sicker?
Yes, typically.
Okay. Yeah, I mean, you've probably seen in your practice that's still pretty young, hundreds and hundreds of common colds?
Yes.
That's something completely different. Would you agree?
Yes.
Okay. I mean, in other words, a person who's got pneumonia for a period of days doesn't look like they have a common cold.
Not typically, no.
Okay. Now, you explained how we go from pneumonia to sepsis and then what sepsis is. If sepsis then in a patient goes untreated, can it lead to meningitis?
Yes.
And would you explain then what meningitis is? And this is a continuum for a patient who starts off with pneumonia, is that right?
It can be.
Okay. And right, if left untreated, and if this is the ugly course that it takes, this is what happens.
Yes.
Then would you explain you already explained to the jury that the sepsis is the inflammation that's now going on in the body, and the body's not able to fight all of it anymore. What's going on then when you get to the stage of meningitis?
Basically, kind of like I said earlier, you got this overwhelming inflammatory response where your body's trying to help itself, trying to kill this infection, but in doing so damages its own blood vessels, and even there's this thing called the blood-brain barrier, which keeps our cerebrospinal fluid, the fluid that surrounds our brain and spinal cord, separate and protected. With sepsis and the inflammation, it can cause that to also weaken. So then what's in the blood can more easily get into the cerebrospinal fluid, which surrounds the brain and the spinal cord. So, the body gets overloaded, overwhelmed, inflammation goes up, blood vessels and blood-brain barriers start to get more permeable or leaky, and then the infection can get into the cerebrospinal fluid and therefore the brain.
All right. Now, if meningitis is left untreated, what's going to happen, doctor? If it's left untreated in a timely manner?
Fatal. The patient will die.
Okay. And let's go back through these then. Is this what the doctors at Via Christi determined that Mr. Bruner suffered and succumbed to?
Yes.
Okay. And I understand he had other comorbidities. You're aware of his liver disease?
Yes.
And so you have his complete medical picture, at least as far as you can tell in that snapshot of the 10th, 11th, and 12th. Is that correct?
Yeah, I don't know if I'd say his complete medical hit, but yes, we knew he had liver disease, and what's in the record is what we were aware of.
Okay. And again, what you're saying is that this is a person who contracted pneumonia at some point in time. It went untreated. It led to sepsis in the manner you described. It went untreated. It led to meningitis. It went untreated, timely, and then he died because of that process.
Yes.
All right. Could you tell the jury what would be you were going to treat the pneumonia? What would you treat the pneumonia with? What would all that would be necessary?
Quite simply, antibiotics.
So if you just give a patient like that antibiotics during the stage of pneumonia, which can last for days, I assume, or short, is that correct?
It can vary, but yeah.
Okay. If you give them antibiotics, that can save them.
It can, yes.
And if it gets to sepsis, what do you do to then, doctor, treat the patient?
If somebody comes to me that hasn't been seen with sepsis, the first thing you still do is antibiotics. And beyond that, it depends on the situation. With sepsis, a lot of times there's other things going on, multi-organ failure, hypotension or low blood pressure, respiratory failure, et cetera, et cetera. So, the very first and primary thing is to get rid of the source of the problem, which is antibiotics. But then beyond that, you can do steroids, respiratory support, et cetera.
Okay, so depending on what stage of the sepsis you get the patient, there may be a need to help them with the blood pressure. There may be a need to help them with other organs that are in trouble. But to treat the sepsis, you treat them with antibiotics again.
Correct.
And that can save them.
Correct.
And if you need to give the supportive care while the antibiotics are doing their work, you can do that and still save the patient.
Hopefully, yes.
Okay. And then if it gets to the point where the patient gets meningitis, what do you do to treat them?
If they come to you at that point and they haven't already been treated, then antibiotics.
Antibiotics again. And then steroids, I think you mentioned.
Yes.
And would you tell the jury whether or not these are common in hospitals now?
Yes.
Okay. And whether or not
Standard of care.
this is standard of care and hospitals treat people like this all the time?
Yes.
Antibiotics, of course, steroids, you can save a person with meningitis.
Yes.
Doctor, were you able to, you and the rest of the team, able to save Terry Bruner?
No.
He died.
Yes.
And what was ultimately the final straw? I mean, what went, how did he die?
I would say at the point that we finally said Terry Bruner's gone and the ultimate cause of death, the pressure in his skull got high enough that it pushed the cerebellar tonsils, is one of the bottom parts of the brain, pushed it through. It's called the foramen magnum, the big opening in the bottom of the skull. The pressure got high enough that those came through the bottom of the skull. It's called uncal herniation.
Okay. Now, I want to talk about this poorly written chart that I've created just for a couple seconds more, and then I'll be done with it. But
Okay.
if we still have the same process going on, and it's with someone who has cirrhosis, you can still treat them with antibiotics in the different phases that we've talked about, and you can save them.
Potentially, yes.
Okay. You don't know how Terry Bruner was able to deteriorate to the point where he got to the way he looked when he was in your hospital.
No.
If someone has pneumonia and they're not eating and they can't take in fluids and they're vomiting, what does that do to them, their body, this fighting off that has to be done? What toll does it take? Can you describe that?
So pneumonia, not eating, vomiting.
Yes.
What toll does that take on the body? I mean, in general, it's kind of a difficult question because, I mean, we're talking hypothetically, and it's very patient dependent as far as how long a person could tolerate that. But they would eventually just get sicker and sicker, more debilitated, more dehydrated. It would just, I guess, I don't know how to answer that completely, I guess.
I think you have.
Okay.
Thank you. I don't have any more questions.
Okay.
Cross-examination.
Now, you were a resident at the hospital at the time you saw Terry Bruner, is that
Yes, sir.
correct?
Mm-hmm.
And you had graduated from what medical school?
KU, Kansas University.
And one of your professors, did that include Dr. Jerry Petrie?
Yes.
And Dr. Jerry Petrie is a doctor that specializes in infectious disease, is that correct?
Yes.
And would he have been someone who would have instructed you concerning the signs, symptoms, and treatments of meningitis?
Yes.
And is he in your, what's his reputation?
He's a good doctor.
Now, you talked about what you saw with Mr. Bruner and the sequence when you saw him at the hospital, but is it fair to say that you're not expressing any opinion as to what Mr. Bruner would have looked like and what symptoms he would have had when he was 2, 3, 4 hours before you saw him?
It'd be speculation if I said what he looked like before I saw him.
I mean, the reality of it is that you say that these symptoms are all kind of patient dependent. They can vary from patient to patient. It's been your experience.
What symptoms in general? I mean, I guess.
Well, the symptoms.
I mean, everybody can look.
Yeah, I mean,
different.
obviously, you're looking for symptoms to make the diagnosis, but in terms of how the disease progresses, that's all very patient dependent. Is that correct?
Yes.
So to try to reach back and say, based on your observations on March 10, what in the evening in March 11, what Mr. Bruner looked like at, say, 3 p.m. in March 10, or what he looked like at 7, that would, on your part, require you to speculate. You don't have an opinion on that one way or the other.
Yeah, I mean, it's not my place to say.
I mean, because when you saw him, he looked sick, and he was very sick.
Yes.
I mean, as a practical matter, despite your efforts, he was going to die.
Correct.
But that doesn't tell you as a trained physician what he looked like at 3 p.m. or what he looked like at 7 o'clock in the morning before you saw him. Is that correct?
Yes, correct.
Now, the type of pneumonia that Mr. Bruner had, was it streptococcal pneumonia?
Yes.
What is that?
It's a gram-positive bacteria that causes multiple infections. It's the most common cause of pneumonia. When you hear people talk about getting their pneumonia shot, that's what it's against, is strep pneumo.
And in the initial onset of that, of bacterial meningitis, well, let me back up for a second. That ultimately led to the meningitis, is what you concluded. Is that right?
Correct.
And the meningitis here, there are different types of meningitis, but this in particular was bacterial meningitis. Is that right?
Hmm?
What was the bacteria?
The same bacteria, strep pneumonia.
Okay. And the initial onset of this bacterial meningitis from that sort of organism, that strep pneumonia, the clinical signs would be maybe the same thing that you might see with an individual who has a common cold or the flu. Isn't that right?
That's a tricky one, because I guess, tell me what symptoms you're talking, if it's okay, tell me what symptoms you're talking about, and I'll say if you can see it with the cold or not.
Okay. But however it might appear, you'd defer to Dr. Petrie's description of what those initial symptoms are. Is that right?
I mean, I can have my own opinions.
Okay. What is superlative meningitis, consistent with the organism of streptococcal pneumonia?
Superlative basically means pus formation.
And is that what was going on here, the pus formation that led to in the process to the meningitis?
I mean, the bacteria crossing the barrier and getting into the cerebrospinal fluid is ultimately what caused the meningitis.
Okay. And that manifests itself when it happens in the pus formations?
Correct, yes.
And when that's happening, the symptoms could be consistent, could be loss of appetite, confusion, maybe even vomiting.
Yes.
And these symptoms would look kind of like the symptoms that you would have with a common cold, or could have with a common cold or a viral infection such as the flu.
The flu, yes. I mean, definitely.
Okay.
Common cold, the only problem I have with that is that common cold typically congestion, runny nose, cough, maybe low-grade fever, but if somebody comes to me with confusion or lethargy, I'm not thinking common cold.
Now, Terry Bruner had some comorbidities. What does that mean?
Other illnesses or disease processes.
What other processes did he have?
His big one, from my knowledge, was the liver disease or cirrhosis.
And because he has comorbidities, that affects the ability of a physician to be able to successfully treat him when he presents himself as he did in the hospital.
True.
In other words, the probability or his ability to be treated successfully with antibiotics and steroids is dramatically affected by the other comorbidities. That in this instance, that's the cirrhosis of the liver and the hepatitis C. Is that right?
Yeah, it's less, yes.
And you had available to you, when you were treating him, the medical records at Via Christi. Did you also have medical records that were available at the jail clinic? Do you remember?
No, sir.
So you just had basically your own observation, correct?
Correct.
You didn't have the records from the Hutchinson Correctional Institute where he'd come before he came to the jail, nor did you have the records from his treatments at Wesley. Is that right?
Right, correct. Not at the time I saw him.
So to be able for you to express an opinion on exactly how likely it was that Mr. Bruner would have survived the meningitis and other issues he had, you'd have to have more information than you currently possess. Is that right?
At what point, like when I saw him?
Well, you saw him. He wasn't going to survive.
Correct.
Yeah.
Correct. Yes. So I wouldn't need anything at that point.
To work backward in the progression of this disease to try to decide what his ability to be successfully treated, you'd really have to know the rest of his story. You'd have to have those other medical records.
You'd have to be there. You'd have to see the whole picture.
Yeah. So you don't have any opinion on whether he really could have been successfully treated with steroids and antibiotics if maybe he was taken to the hospital at 3 or 7 that morning, for that matter.
I couldn't. I mean.
Now you've talked about with counsel a sequence here, and it's kind of up here on the board here, where we start with pneumonia, we go to sepsis, and we work our way to meningitis. Is that always the sequence with pneumonia?
No.
I mean, you can have pneumonia and it doesn't lead to sepsis, right?
Correct.
You can have sepsis and it doesn't lead to meningitis, right?
Correct.
Okay. So this is just when you were saying that's the sequence, that's what happened with Mr. Bruner, not necessarily that that's the consistent or always the sequence. Is that right?
Correct.
In Plaintiff Exhibit 4, there's a history and physical that I think you were shown, and I'm going to put that up, portion of it in front of you. It says history and physical, mission date 3/10/08, and it kind of works its way eventually where it's got, although this one isn't signed, there we go. It has your signature line down on the bottom, the second page. When is the history and physical prepared, sir?
Immediately upon seeing the patient.
Okay. And in this instance, this would have been, there's at the very back of it, and I know you don't have it in front of you, but it shows that it was dictated early in the morning, I guess, on the 11th, but it would have been based on your observations that were when you were treating him earlier on the 10th. Is that right?
Right.
The examination records where it says physical examination, would that have been something that someone had done? This reports this particular form, how Mr. Bruner was at what time?
That would have been when I first saw him.
Okay. And there's a record in here that shows in Exhibit 4 that he first got to the hospital at 9:53. That would be when he arrived at Via Christi, but you would have seen him sometime after that.
Right.
And there's a record, and I don't know if this will help or not, but there's a record of a history and physical examination in Exhibit 4 that shows a time of, 9:26. History of physical shows attending physician Dr. Nat Vig. Would that have been about the time that you would have first seen him?
Yeah, what this is, if I can clarify.
Sure.
This basically, what we do as residents, and 4 years ago, I don't remember that night, but we basically, we go in, we see the patient, we assess, we get orders, we get moving. A lot of times this handwritten, this really, I'm surprised this is part of the medical record, because that's almost like a note, like a cheat sheet or a note card, just to take some observations, and then we go back and use that to dictate. So it's kind of one and the same, but basically I would have used this sheet to dictate my H&P.
Okay, is that your signature then?
Yep.
Okay, and so on another page of this same document, oops, that's where we've got, we've got nursing, vitals, respiratory care, radiology, and so forth. So that's where the history, when later we look at the physical examination information, that's where we gather that, right?
This here is actually an order set that you have up right now.
Oh, okay.
So as opposed to a
Right.
note.
Okay. So this is the document that we'd look at, and whatever other parts of it.
Right. That and the
Okay.
dictated H&P are kind of connected.
Okay. Well, if this shows that it was at around 9:26, that would tell us about the time these vitals were taken. Is that how that works?
And I think that would have been 11.
Oh, I'm sorry, you're right.
But yes.
That would have been 11:26 that evening, wouldn't it?
Yes.
Okay. Now, going through the vital signs then, just right before midnight, he has a temperature of 100.4 rectally, and that would be consistent with a man that at that point had an elevated temperature, correct?
Correct.
He had a blood pressure of 155/99, and is that a high blood pressure?
It's mildly elevated, yes.
And it says no hypotension. What is hypotension?
Low blood pressure.
And a pulse of 114. Is that an elevated pulse?
Yes, sir.
At that point, he was on a mechanical ventilator for respiration. Is that right?
Yes, sir.
What does that mean?
He's no longer breathing on his own. He has a machine breathing for him.
And then it's, well, that's this
That's the.
IMV title mode, or volume 60 talks about the ventilation, right?
It's just the settings on the machine.
And inspiratory pressure of 10, what is that?
Once again, just another setting on. You can change that. It's just a dial. It's how much air it pushes into his lungs. Keep
The
him
same as the PEEP of 5 and the rate of 10, is that
right.
right?
All settings.
At that point, he's intubated. What does that mean?
I guess it's kind of redundant, but it just means he's got the breathing tube down.
And his pupils are equal, fixed, dilated. What is the significance of that?
And I'll just admit right now that I must have misspoke, because it says pupils are equal, and then later I talk about how they're different size, so I was probably going too fast. But
Okay.
Fixed and dilated would be the important thing there. Fixed meaning that they don't change when you shine a light in them. Dilated just means that they're open wide.
The next page talks about approximately 4 mm left, 3 mm. What is that referring to?
The size of his pupils.
Okay. Now, you had indicated, I think, to counsel that when you saw him, one of the things you try to do is get a response by pushing him, pricking him, trying to get a pain response, right? And you received no response at all.
Correct.
Do you know how long he had been non-responsive to any sort of painful stimuli?
I don't know.
But at least by the time you saw him, he's unconscious, he's unable to breathe by himself, and he's not feeling any pain.
Correct.
Now, it goes on to say neck supple with, and that's a long word, what is it? how's that word read?
Lymphadenopathy,
What does that mean?
big lymph nodes that you can feel.
So he didn't have a big lymph node, and he had a supple neck. What's a supple neck?
And a supple basically means that you can move it without pain, and so that then the question would be, if he's unconscious, how's he supple? A lot of times, if it's not stiff, if it's not rigid, you'll say supple.
Moving to abdomen, soft, no, and what's that word?
Hepatosplenomegaly,
And it means?
large liver or spleen.
Appreciated. What does no large liver or spleen appreciated mean?
On exam, when I pushed on his abdomen, I couldn't feel his spleen or liver. Typically, they're tucked up under your ribs, so you shouldn't be able to feel a liver or spleen.
Okay, now, if you had someone who had a midsection that is so distended that it looks like a mountain, would that have been something that when you had made your examination of the abdomen you would have reflected?
I don't know how to answer that. I'd have to see. It depend on the patient, I guess. Depend
Okay,
on
well, if you've got someone who, and not from an obvious weight issue, but who has a distended belly that's sticking out like a mountain, what's that medical condition for that? What would be the description of that?
depend on the cause. It could be bowel obstruction. It could be ascites. It could be.
No, rather than talking about the cause, how would you describe it in your records? Would it be called distended abdomen? Would that be the?
Yes.
Okay. And if it's a distended abdomen, so much so that it's noticeable, a mountain, would that be reflected in your history under abdomen or someplace else?
Probably abdomen.
Okay. And then you've got the bounding pulses here, both in the neck as well as the extremities. And you've talked about that with counsel. That's where, as you indicated, the veins are such that you could kind of just almost literally see the pulse, right? Mm-hmm. Where's the pulse rate? Did we look at that? That would have been the elevated pulse rate of 114, right?
Right.
In Plaintiff's Exhibit 2, there's some records taken by a nurse that shows they've got a 93%. Do you understand what I don't know if that's VS 93% relates to?
Yes.
And what does it relate to?
Is oxygen saturation.
And someone with an oxygen saturation of 93%, what does that indicate as to his status with pneumonia?
It means it's starting to cause mild hypoxia, or his lungs aren't exchanging oxygen like they should.
So you'd like ideally to be 100%?
Typically 98. I mean, it kind of depends. In a healthy person, 98, 99.
Okay, so this would indicate kind of the beginning of the process if it's 93%?
Depends on the process.
And the 74, what would that have meant?
I assume his pulse.
And that would, a pulse of 74 is now really more range of normal, right?
Yes, sir.
And the temperature, we've got 100.4 here and 100.1 there, so the temperature would be elevated in both instances above what is considered to be normal, right?
Correct.
Some of us have a higher temperature than others, though, is that right?
Yes.
And then this 118/78, that's the blood pressure.
Yes, sir.
And that compares, well, that's not only normal, that's really pretty good blood pressure, isn't it?
It's a normal blood pressure.
Okay. That's not the elevated blood pressure that he had when you saw him, right?
Right.
When you get to a good stopping point, would you let me know so we can take a break?
This is as good as any, Your Honor.
Okay. Then, members of the jury, let's take a 15-minute recess and we will reconvene at 25 minutes after 11. Court's in recess.
All rise.